Before we had an access to ALK tyrosine kinase inhibitors, ALK mutation signified worse prognosis. We have several studies published looking at response rates to chemotherapy, comparing response rates to chemotherapy in patients with ALK rearrangements and without ALK rearrangements, and patients with ALK rearrangements respond to chemotherapy less well, with an exception of pemetrexed. Also, we have data published by Young, who looked at 5 years progression or recurrence-free risk for patients with ALK rearrangements, and we know that ALK patients are twice as likely to progress or recur 5 years from the time of the diagnosis. Currently, in the United States, for patients with newly diagnosed metastatic ALK-rearranged lung cancer, we have 3 drugs approved. Crizotinib was the first drug approved, ceritinib, as well as alectinib. 2 of those drugs, crizotinib and ceritinib, had a first-line studies comparing it to chemotherapy. Alectinib is the only ALK inhibitor which has a first-line trial comparing it to another ALK inhibitor, which is crizotinib. My personal choice is alectinib because it has been shown to result in the longest ever reported progression-free survival. The data, which will be updated with ASCA, now showing progression-free survival on alectinib of 34 months. This is actually remarkable to even imagine that we have patients with stage 4 lung cancer which are still receiving first-line therapy 3 years at the time of their diagnosis. The major breakthrough in this setting is approval of alectinib first-line and significant efficacy of alectinib, both systemically as well as in CNS. This patient response to crizotinib was as expected. Based on profile 1014, we know that response to crizotinib ranges between 70 to 80%. The progression-free survival has been reported at about 10.9 months. So the fact that this patient progressed at 12 months of therapy, this is something that we would expect. Unfortunately, all the patients will develop resistance to ALK inhibitors. Post-progression biopsies have been done in patients who develop resistance to crizotinib. What we learned from that is about 1/3 of the patients will develop resistance in ALK domain. We call them ALK-dependent resistance. Majority of those patients develop secondary mutation in ALK domain, and this patient had a mutation 1171. Based on the preclinical data, we know that this mutation predicts resistance to alectinib. Brigatinib, however, covers that mutation completely. And another important mutation that is emerging to be pan-resistant is 1202R, and brigatinib is another drug that has activity against that mutation. Neither ceritinib or alectinib is active against 1202R. In a patient who has progressed post-crizotinib, doing post-progression biopsy could be recommended. If you have an information about specific point mutation in ALK domain, then you can refer yourself to published information looking at sensitivity of second-generation ALK inhibitors against a specific mutation. We do have approved drugs as well as upcoming drugs which cover majority of the resistant mutations. So if my personal feeling is that if you decide to use brigatinib, which covers majority of the resistance mutations, you might forego the biopsy. But if you think in between ceritinib and alectinib, I think it is important to know that mutation, which is a resistant mutation to crizotinib, is covered by the drug that you choose. Another important information is the fact that you do not have to have a resistant mutation in ALK domain to respond to second-generation ALK inhibitors. So if you did a post-progression biopsy and you found that the patient have a wild type, meaning non-mutated but still rearranged ALK, you still have a possibility of this patient responding to second-generation ALK inhibitors. If one looks at the reported responses for second-generation ALK inhibitors, they range anywhere between 60 to 70%. But ALK point mutations only happen in about 30% of the patients. So the rest of the responders do not have an ALK point mutation.